Welcome to Inspiring Women with Laurie McGraw. I am your host, Laurie McGraw. I have spent the past 30 years in leadership, and over the years, I've come to learn one thing. Women need women, and not just any women, but inspiring women. Tune in every week to hear from women at the pinnacle of their careers and from others who are just starting out. Episodes can be found at inspiringwomen.show or subscribe on your favorite podcast app. Thanks for listening, and I hope you will be inspired. This is Inspiring Women, and I am Laurie McGraw. Today, I am speaking with Dr. Kimberly McKay. She is the Clinical Vice President of the OB/GYN service line at Avera Health, which is an integrated health system based in Sioux Falls, South Dakota. Dr. McKay is a practicing OB/GYN physician. She's dedicated her career to improving the state of maternal health. And earlier this year, she joined PeriGen, which is a perinatal software solutions company, as a physician consultant. And Dr. McKay, thank you for being on Inspiring Women.
Thank you for having me.
Well, let's get started. I always start Inspiring Women by just asking, what are you doing right now? What is your day-to-day as both a practicing physician, as a leader of a service line, as a physician consultant to an innovative software solutions company?
Well, what I'm doing right now is I'm now actually the Chief Medical Officer for PeriGen, and as well as the Clinical Vice President of Avera Health. And
Congratulations. Congratulations.
Thank you. I know both of my bosses have been just phenomenal about working with me because I've done a ton of work in the Avera Health system, have more work to do, but certainly have a great desire to work with software companies like PeriGen who help the people work smarter because medical error is still very real. And these are the kinds of things that I think help with that. And the other thing I'm doing right now is that Avera was just awarded a HRSA grant for $1 million a year for the next 4 years to address maternal health. And that's called an Our Moms grant. It is, we've tried it a couple times and finally this is the big one. So, the next 5 to 7 years of my career are really going to be set around the work I'm doing with these two entities.
Well, that is great. And I want to talk about sort of, what is possible in terms of improvement, because the state of maternal health, today is certainly not where it should be, and actually going in the wrong direction from just the recent, announcement from the CDC about 80% of maternal deaths, maternal health deaths being preventable, pregnancy-related deaths. So I want to talk about the state of play there. But before we do, Kim, can we just go into a little bit of your background? So you came into medicine. Why did you want to be a physician, and why did you, turn to maternal health as your area of expertise and focus?
I had a bit of a winding journey. I'm from a little town called Belfouche, South Dakota. It's a ranching community on the western side of the state. And I was one of the this was back in the 80s and 90s. I was one of the smart girls in the class. And, at the time, women were really going into like teaching. And I knew I did not want to do that. And my parents both were teachers. I wanted to do something that was both financially kind of stable. Back in the 80s during the Reagan era, we didn't have a lot extra laying around. I remember, helping my mom deliver bills just by hand because we didn't really afford the stamps. I mean, we had enough, like everybody was kind of in the same position, but, I just thought, what can I do that is a little bit better than teachers? Like it's a steady financial income, but also is really, where I can be smart. And that really was medicine. Obviously there's so much more than that now, but when I was, I think an 8th grader, I won the state science fair contest to do with chickens. And we can talk about that later, but that really started this sort of, interest in real, like, I just love science and I love the research. And was able to, get scholarships based on that to the University of South Dakota. And knowing that I wanted to go into medical school. And at the time, medical school was, as a woman, you had to be perfect. Like you couldn't, you had to have a 4.0 and your MCAT scores had to be stellar and you had to have the research and be well-rounded. And there weren't very many of those opportunities, in particular for research at the time, and in particular for women. So I kind of had to, find those opportunities for myself. Ended up getting into medical school. And then in medical school, I was pretty sure I was going to be a pediatrician. And it took me about 4 days on the pediatric wards to be like, this is not my deal. It's not, because kids don't talk and parents are, intense. And so, but I ended up having a mentor, which I know you've spoken about before, how important it is to have mentors. And it happened to be a man, Dr. Burnett, who had delivered my little brother, as it turned out, way back in the day. And he pulled me aside and he said, listen, you're really good. He was an obstetrician, great surgeon. He goes, you're really good at surgery and you're really good with this patient population. And I think you need to go into this. And so, and that was maybe 2 weeks into my rotation. And that's when I really had
so encouraging. Here, those words of just pointing out when you're working so hard at trying to figure out sort of your career journey, your profession, and what, that you were, the intense parents and the non-talking kids sort of like turned you off when you just started.
Like, no.
To hear that you're great at something must have felt terrific.
Well, and it took me by surprise because, again, at the time, surgeons, any surgical subspecialty was men. And even though mine was the first medical school class that had women in it, surgical subspecialties, by and large, were men. And so, it was just to have somebody recognize, he's like, you've got really good hands for surgery. And any surgeon who listens to this will know what you mean. When you see someone who can see how to handle tissue, who's just intuitive in the OR, that's a really special skill set. And to have this, 65-year-old renowned surgeon for the area sort of say, listen, you're really good. I was like, oh, wow. And so from then on, I paid attention to those surgical subspecialties and then ultimately settled on obstetrics because it was a healthy population. It's a really interesting field, and it's a very practical field. I'm pretty smart, but my smartness is more in practicality and common sense. Versus the real cerebral work around, say, like rheumatology. I'm an identical twin, and my identical twin is an internal medicine hospitalist kind of physician, now working for Google Health, as it turns out. Yeah, so she and I have had kind of these parallel journeys, but she's just much more intellectual than I am. So anyway, did residency down at the University of Kansas in Wichita, lots of babies, lots of bread and butter stuff. And I didn't have any thought of, maternal health, but during my time in residency, I went through a lawsuit and spent the last 9 weeks of my medical school in residency going to trial for 9 weeks, and which was traumatic. And the whole time I was sitting there, I was like, how do you prevent this from happening? Not just like the outcome, but, it was such a place of like, poor communication and medical error potentially. And I don't remember all the particulars of the case, but really where I started was in patient safety and helping teams, like, how do you do this work better and communicate better so that patients understand that no matter what's happening in the context of their labor, if there's a bad outcome, how do you help patients understand that you did everything that you could?
Yeah, well, the whole area of patient safety and certainly, for physicians, malpractice as an expense, and also so that we're in a state where just sort of lots of lawyers involved in medicine, lots of lawsuits, and physicians that I speak with, the idea of being, or not the idea, but it happens. You get sued, you have to deal with it, and it is traumatic. And in the specialty of OBGYN, the rates are even higher in terms of those lawsuits. And it makes sense just in terms of, again, practically why that would be, just given the state of play with pregnancy-related deaths and incidents of that. So, Kim, just moving to, let's talk about maternal health, because you run the service line of OBGYN at Avera, and so you've really been focusing there for a long time now. What is the state of play? I mentioned the new CDC information of 80%, over 80% of pregnancy-related deaths are preventable, but the United States has not a good track record, amazingly, for mothers for giving birth. So what is the state of play for maternal health?
So it can be different everywhere, but in general, there's preventable death within the four walls of the hospital that have to do with hypertension and hemorrhage. Those actually aren't as high as you would think they were. And then there's this, the first 7 days after a patient dies or after a patient leaves the hospital, those tend to be cardiac events. And then there's this whole slug of stuff that has everything to do with mental health. Mm-hmm. And has to do with what I think are like gaps in service. So, about 40, depending on where you are, 40 to 50% of births are covered by state Medicaid. Many times state Medicaid ends at 6 weeks postpartum. And so any of these comorbid conditions like hypertension, diabetes, mental health, substance use, any of those things that co-occurred during the pregnancy, they can no longer be addressed after 6 weeks. We've seen a number of states make policy changes and start to cover those kinds of, cover Medicaid for moms up to a year postpartum. But there are plenty of other states that have not, South Dakota being one of them. And so, again, the gaps really are not around the pregnancy itself, but around the comorbid conditions that occur with them.
Okay. But so did you say that 40% of pregnancies or births are covered by Medicaid? That's the coverage at 40%? Huh. That's a lot. That's a lot. But so these issues, I mean, certainly globally, the world has babies. So why is the United States so particularly bad? If we look at, progressive countries, the United States is actually, at the very low end of the scale in terms of, the health of mothers and healthy babies. Why is it so particularly difficult here in the United States?
So I think a couple of reasons. I think in particular around preventable things like mental health. So when we talk about mental health conditions being a cause of maternal morbidity and mortality, what we're talking about is overdoses. We're talking about motor vehicle crashes while you're driving drunk because you didn't have the resources to maintain your sobriety. We're talking about again, really severe depression and those kind of things. Those are conditions that most, number one, it's, if you're covered by Medicaid, those are not going to be covered services once your Medicaid coverage ends. In South Dakota, in particular, we have a lot of, when patients access care in our facilities, when they're pregnant and shortly after they're pregnant, there are a lot of biases about pregnancy in and of itself, and certainly around race and ethnicity, I think that we see. The state of South Dakota has not released their maternal mortality data yet. I do sit on that committee and I'm not at liberty to say what the findings are, but needless to say, But I'll give you an example of just something that we actually see in real life. When a pregnant patient comes in postpartum and is tachycardic, there are a number of reasons a pregnant woman could be tachycardic, but there are times when people say, you know what, you're just anxious. And the reason you're tachycardic is you're anxious and you need to settle down, you need to calm down. Well, then they don't do the CT scan for the pulmonary embolus, and they don't do the EKG, and they don't address maybe the blood pressure that's a little bit elevated, and they send a patient home who actually has a medical problem. So again, I can speak to South Dakota and my own health system. I would also say that rurality plays a huge role in South Dakota because getting access to prenatal care just from, in the first trimester for a number of our patients is difficult, both because of the drive, there may not be a provider. And also if you're signing up for Medicaid, there's kind of this lag in coverage. So that's one thing we need to address within our own state. One of the things that Avera, that I started out doing really from a patient safety standpoint, but really has morphed into this maternal morbidity thing, is said to all of our 16 delivering facilities is, how do we provide quality care at your facility, even if you don't have all the resources? And what's an evacuation plan if a mom's bleeding? So the Avera Health System has done a lot of work around protocols and things like that. We're now participating in the Premier Health and Human Services Perinatal Collaborative set and are looking for lessons learned there. And we know we have some gaps in care, in particular around substance use disorder and depression. And, that's probably going to be our next big project. So that's, it's multifaceted, and you can get really overwhelmed at all of the what's of it. The United States as a whole, could I knock it down to, do we need just a single payer system so that we don't have access problems to care? I don't know the answer to that. Medicaid's such a different animal because every state has a different Medicaid kind of service. And at the end of the day, I think we as providers just have to be, aware of our own internal biases and aware of where there are gaps in our own health system that we need to sort of figure out how to bring together.
Well, this is, it's really helpful to hear the collection of issues, and that really expresses the complexity of solving it, whether it's lapse of coverage, you've got payment issues, bias, probably systemic racism is involved in some of that bias. You've got mental health issues, which we know are only getting worse. And this is pandemic and substance use and other things related. So there were lots of discussion and studies in that area. Also really helpful to hear about the depression and other types of multiple disorders that people are dealing with. So with all that probably, overwhelming at times, information, what is working? What can be done that you feel it sort of has promise? And I'm sure it's many different things, but where are some of the areas that you're feeling encouraged and really wanting to focus on?
Two areas. I think the first area being really looking at your community, and that's what our Moms grant is about at Avera, is reaching into the communities and understanding the needs. And so having community health workers, the state of South Dakota has given a number of grants for community health workers, and they are working, meaning people who understand the community, know the patients, can go drive a patient, bring them to their appointment, sit with their kids in the waiting room, do a social determinants of health, understand that maybe if the patient's gestational diabetic, we need to go to the grocery store and maybe go shopping with them and help them pick some things out or pick some healthy meals. So again, understanding the community and getting the wraparound services like Department of Social Services, like WIC, like our care coordination, getting those pieces to talk to each other, which sounds stupid in this day and age, but it's actually really hard. And
I think so many people experience that in terms of the connection points in healthcare. As somebody who has been in healthcare for over 30 years on the technology and innovation side, when you experience it as just a person in the system or a family member that you're trying to support, those gaps and a connection point, they're everywhere in the smallest of ways that make such significant differences.
Well, and I would just tag on to that, that the second solution, just in my opinion, is, okay, we've got all this great technology. Now let's find the levers, right? How do we help the humans? How do we help the humans work smarter, not harder? How do we make these connections more seamless? And actually, that's why I work for PeriGen, is the way that they aggregate and monitor the data allows me to not have to look so frequently, and then flags me for when I need to actually pay really close attention. And I think EHRs do it okay. I think we're learning more and more about how to work with the humans who are doing the job. But, my goal at the end of our Moms project is really to help those connections just happen kind of automatically.
Well, it's so important, I think. I mean, you're a user of technology, and I know that you're a user of the system at PeriGen as well. But for physicians specifically who are experiencing the technology to make those connection points, I say this just, having lived it in terms of implementing systems. Maybe Kim, let's talk a little bit more about you as a physician. And it's no secret that physicians are significantly more burnt out than other professions at that level. And we also know that there is just a tremendous amount of pressure, whether it's technology that's getting in the way, or just people generally not believing science like they used to, a lot of disinformation that's out there. How are you doing, like in terms of just your own sort of like staying energized and committed to medicine, just given the state of what's happening with physicians generally?
So the COVID was rough. Like, I never want to do that again, where I was terrified for my kids, standing in a room with patients. And one of the things that was really kind of a bummer is that people really rallied around, okay, if you're a healthcare worker and you're not in an aerosol generating procedure, then you don't have to worry about anything. Well, here we are on labor and delivery, where all of our patients come in, we see whomever we want. And they said, well, then you're in a room pushing for 3 hours with a patient. And people didn't believe that we needed personal protective equipment. And so it was a bit of a moral injury, right? Because now we know, of course, that pushing during labor actually has very high respiratory transmission rates. And, sort of having to go to my administration, who, thankfully I work for a great administration, but, certainly to see in the data that it just wasn't being supported. And again, I'm like, yeah, go figure. It's women's health. Like, we're always we're not well reimbursed. We're always kind of the last thing that everyone thinks of. And as it turns out, we're kind of the canary in the cage we were the canary in the cage for the pandemic, because we had patients who were showing up who were really, really sick, and we still had to take care of them. So I think what that did for me is said, okay, when I came through that, I started paying attention to what gives me energy. And what gives me energy is helping solve problems for physicians when they're burned out. So again, workflows, making their lives easier. I'm also kind of at a point where I get to now start mentoring people and giving them sort of like, okay, providing and creating opportunities for other women, other physicians who want to be in leadership. That gives me a lot of energy. And then the other thing I haven't mentioned is, as an old mama, my husband and I met late. I put off childbearing until I had my first when I was 38, my second when I was 40. So even though I'm pushing 50, I have this 9 and an 11-year-old who are just a blast. And so I think I get the fear of missing out sometimes on if I don't appear at every meeting or do every little thing. Because in women in leadership, we want women in leadership, but then something that can happen is if you don't show up for the meeting, somebody might take your place, right? So there's always that fear of like, I'm going to be replaced. And I had to just like put that away and say, you know what, I've got a great life. I've got great kids. I've got supportive bosses. And now I'm going to go where I feel energized and feel like I'm helping.
Well, it's so awesome to hear that energy come through. And also just that you're taking, just like the difficulty, and it was difficult, the pandemic. And as a physician and a physician leader, just hearing your story is hard to hear, but that you're coming out of it with sort of renewed energy. I also really do appreciate the comments on mentoring. Encourage all women, to mentor others, and that it gives you energy, doesn't sort of take just time, is wonderful to hear. Kim, there's so many things that I'd love to talk to you about, but just because of time here, I'd love to close out on this interview with just, if we look out in the next 5 to 10 years, what do you think is possible for maternal health in terms of what can be done?
I think what's possible is to take all this really good data that we have and really use it to make both policy change and payment reform around maternal health. At the end of the day, and this is a sad fact, if you want the answers to maternal health, follow the money. I want you to go look up the reimbursement for a hip bundle on the Medicare side. And then I want you to go look up the reimbursement for a complicated length of stay of 5 days ICU admission for maternal health. And at the end of the day, we are investing a lot of resources in fixing problems that are to do with, obesity and diabetes and those kind of things. And now the buzzword is population health, right? So population health, manage the health of your population. That starts with a mom and a baby and a pregnancy. You have to start there. That's the ultimate population health strategy. But in our current policy and reimbursement world, that's going to be really hard. So in the next 5 years, what's possible, I think I don't even want to think of it in terms of being possible. It's a must. We must change this because what we're doing is not sustainable. And in 5 years, I hope to never be in a budget meeting where I hear maternity care is a loss leader. I want to flip the script and say, this is an investment in the health of our people. So that's a must do.
That does sound like a must do. And it's really wonderful to hear, your commitment to using the data to work on changing the policies. Just excellent. So last question, Kim, as we close out, it's been such a great conversation. Any advice for younger women who are just starting out, whether they're thinking about a career in medicine or technology leadership or physician leadership as you're in? Any advice you want to share with listeners?
If you get invited to participate in a meeting, just say yes, because it's, that's always what I've done is just said yes, even if I don't really think it's going to be a long-term thing. My greatest opportunities, my greatest professional relationships have come from somebody saying, hey, I really think this would be a great thing for you to attend to get your thoughts on. So, manage your own internal biases about meetings and leadership and those kind of things, and just say yes.
Okay. Well, we didn't have time to get to the chicken story. I'm sorry about that, but this has been a great Inspiring Women conversation. I've been speaking with Dr. Kim McKay, and Dr. McKay, thank you so much.
Thank you for having me on. I so appreciate it.
This has been an episode of Inspiring Women with Laurie McGraw. Please subscribe, rate, and review. We are produced by Kate Cruz at Executive Podcast Solutions. More episodes can be found on inspiringwomen.show. I am Laurie McGraw, and thank you for listening.